be discussing tobacco cessation and nicotine use disorders. There's a lot of effects from tobacco, and there's really no safe form of tobacco. Dental and dental hygiene professionals are in an ideal position to really discuss this and have great opportunity to assist our patients with tobacco cessation. We're going to discuss, we really want to recognize the health hazards of the tobacco use. I know a lot of us are familiar with them, but we're going to discuss those. We're going to identify different components of the tobacco products. Look at some of the alternative tobacco products. We have dips, we have vapes, there's some others, and then some of the different mechanisms for delivery, how the nicotine is metabolized, and also recognize oral manifestations of tobacco use, which is very important in our intraoral exam. I want to discuss the effects of environmental tobacco smoke, or what is known as secondhand smoke. Also, a dental hygiene care plan for our patient who used tobacco, and then recognize some of the protocols that we can use for tobacco cessation, and hopefully be able to apply these in a case that you develop, and some of the different pharmacotherapies that are applied for some and behavioral to help treat nicotine addiction. Ask our patients and assess if they are using tobacco products, and then if the person is interested in tobacco cessation. And many people cycle through this, and there's a lot of abstinence and also relapse with this. And it's a tobacco dependency or nicotine dependency is a chronic use disorder, and it's very difficult for cessation. And that's why we really want to address this and be able to discuss this with our patients. This is one of the leading aspects in preventable diseases and illnesses in our countries. There's a lot of different trends. It's pretty much preventable for premature death, and also prevent a lot of diseases. Statistics show 1 in 4 Americans report have had used some type of tobacco products, whether it's cigars, little cigarillos, a hookah, e-cigs, smokeless tobacco, and it has declined in the last several years, but we're seeing other things take its place with the alternative tobacco products, such as the electronic nicotine delivery systems, like was mentioned in one of our MDHA meetings in January. Those are very popular, especially as far as with young adults that we're seeing. That has that really nice appeal to it with all the different flavors. And there's a lot, probably about 16 million Americans suffer from some type of disease caused by smoking. And 80% of the lung cancer death are attributed to smoking. A lot of systemic health effects from tobacco use, and it really can cause a lot of cancers of the mouth, the pharynx, stomach, bladder, lungs. Tobacco use can really be related to heart disease and atherosclerosis, COPD, chronic obstructive heart disease, and coronary artery disease. And we can see direct causes with lung causes from emphysema, bronchitis, and smoked tobacco, such as the snuff, which you call sometimes as snus. We'll hear that. That's Norwegian. That's very popular in Norway. And chewing tobacco, even though a lot of people perceive those safer than cigarettes, they still are not really associated with lung cancer and respiratory illnesses, but we definitely see a difference with oral cancers with that. And tobacco use can cause miscarriage, preterm births, low birth weight babies. Also can be attributed to cleft lip, cleft palate, growth malfunction, tooth malformation, and also related to sudden infant death syndrome. Metabolism of nicotine is the absorption in the membranes, primarily the lungs, also through the skin. We have it in the mouth through the oral, buccal, nasal mucosa, and also into the gastrointestinal tract. The delivery method affects the way the nicotine is absorbed in the body. It can also spread very nearly to every part of every other body tissue. It is easier for absorption, say for instance with chewing tobacco, tobacco, it actually has been designed to have a little bit more alkaline pH, actually to improve absorption into the bloodstream. Then there's other factors that from the smoked form, such as cigarettes, pipes, tobaccos, and it's metabolized by the liver and excreted through the urine. Nicotine, when it's smoked, enters the lungs very quickly, and it enters into the circulation through the blood vessels and into the bronchi. The nicotine is delivered into the brain within 20 seconds of use or less. The peak concentration can be different times, but actually peak plasma concentrations of nicotine in the brain usually occurs in about 5 minutes. Nicotine is the primary ingredient. It's a psychoactive ingredient that contributes to the problem of addiction. It is considered toxic, and even 60 milligrams of pure nicotine can be fatal. Once nicotine is ignited or smoked, the carcinogenic substances it's inhaled directly into the lung, and also it's emitted into our environments. If you've ever been around someone who's smoked, cigarette smoke, remember this, is a complex mixture. It's estimated that there is over 7,000 chemical compounds in cigarette smoke in the development of cigarettes. There's over 90 chemical compounds in tobacco products that have been identified from the FDA as either being unsafe or having unsafe potential. So these chemical compounds can be categorized as carcinogens or cancer-causing. They are respiratory and cardiovascular toxicants, and reproductive or developmental intoxicants as well. It's very addictive, and it can be a combination of everything combined that we just discussed. Some of the different things, potential harmful systemic effects. There is acetaldehyde, which can affect the respiratory. Believe it or not, there's cyanide, arsenic, creosoles, which get into the cardiovascular system. And there's also your book has a list of different products and how they're delivered and the different rates of delivery into the system. Alternative tobacco products, also known as ATPs, they are absorbed through the oral cavity and absorbed a little into the intestinal tract as well as it forms into the saliva. The electronic cigarettes are known, they are the e-cigarettes, vape pens, water pipes. They have a dissolvable gel, and they have very varying levels of nicotine and other potentially harmful pieces or aspects to that. They're not considered safe, nor are they a safe alternative to cigarette smoking, even though they're advertised that way. A lot of times they have higher levels of nicotine in them as well, and they have a higher potential of addiction for those. Some of the smokeless tobaccos, the snuff or the dip that's placed in the cheek or the lower lip. And then there's some that's called snuff, and we don't see it quite so much, and it's actually inhaled through the nose. There's some called snus, and it is actually in a little pouch, and it really doesn't require any spitting, but it is held in the pouch just like the spit tobacco is. Usually the loose leaf spit tobaccos, they can get in the teeth. There's different types of sugars, and some of the other cancer-causing substances in there can be formaldehyde. Again, we mentioned arsenic, cadmium. It's directly absorbed through the mucous membranes. Once that's placed in the mouth, it is 3 to 4 times the amount of nicotine that is delivered through a cigarette. And that nicotine concentration steadily increases over the 2 hours use, and then it kind of declines after about 24 hours. Kind of gives an idea of some of the plasma concentrations that you can see. Here is right here where we look at nicotine from a cigarette and how it peaks. And then the next thing we look at the moist snuff. And then we look at some of the different nicotine replacements. They don't have that peak level, and it keeps it a little bit more steady for people that are trying to quit. We can see here's an inhaler, a lozenge, a gum, or a patch, and it keeps those lower levels of nicotine concentration as people are trying to quit. We look at the different systemic effects in this chart. We have the cardiovascular diseases, pulmonary diseases, cancer, tobacco, and other drugs. And each of these diseases that affect these systems can be ranged from mild to deadly. We see smoking is the major cause of COPD, emphysema, and it really just diminishes the person's ability to breathe. Again, remember, smoking is responsible for 80% of the lung cancers that we see. And lung cancer is the current cause of death among cancers for both men and women. Even though it causes different types of cancers, that's the number one. We see pancreatic cancer, bladder cancer, kidney, and all of those, some of those are more difficult to detect, such as liver cancer, pancreatic cancer, cervical cancer, colorectal cancer. And usually when those are detected, they're at a very advanced stage. And also the dip tobacco increasing the incidence of oral cancers. Absorbed into the bloodstream in the form of the nicotine products or the tobacco, it leads to the dependence. And what we see in some of the hallmarks, as mentioned here, of nicotine addiction, it's more of a compulsive use. Someone has to have it. They use it despite they know it's harmful. How many people do we know have smoked and they just keep on doing it? Sometimes they just got to have that cigarette. It makes them feel better. And they build up a tolerance and physical dependence on it. And it's very difficult to quit. And even though people will quit and they may have abstained for years from some type of nicotine use, they'll relapse. So nicotine is highly addictive and very difficult to address the cessation. Aspects that we have to consider of nicotine addiction. This nicotine, again, it's released into the brain, so it releases these chemicals that, remember when we talk about dopamine and the norepinephrine and acetylcholine, serotonin, beta endorphins, all of those, if you remember, those are our feel-good, where that nicotine attaches to those receptors. So the longer they use it, the more nicotine they need to achieve to get that effect, that addiction effect. So they really lose control over its use because it makes them feel good to use it for a short amount of time, but then they have to have more. Tobacco smoke, also known as secondhand smoke, is very toxic. It's passive smoke or involuntary when non-users are involved. It's present in the room air when people start smoking. These chemicals are generated and we breathe around that person when it's breathing and they're puffing, or even with the vaporized, we're still breathing those areas, especially in indoor areas, and hopefully that they're ventilated. My dad was a smoker growing up, and I can remember I did not like it and could feel like I was choking sometimes. So secondhand smoke at any level is unsafe. Approximately 58 million Americans are exposed to some of this passive smoke, and it's really the secondhand smoke or environmental smoke is really most prevalent when those living different socioeconomic levels, multi-millennial rental housing, and then there's a thing called third-hand smoke, and this is something you don't really think about, but it's actually that smoke residue is absorbed into the furnishings or into the paint, or into, if you've ever seen smokers' homes and they take down a picture, there's a sticky residue. You might even see the outline of the picture, and these smoke residues form on even cling to the smoker's clothes, their vehicle, and it's a health hazard to those that are around it. And so there are toxic components in that, in this, especially again, we mentioned the formaldehyde, nicotine, cadmium, carbon monoxide, and there is, of the 250 toxic chemicals in the environmental smoke, there's at least 50 that are associated with cancer. So always keep that in mind when you're around someone that is smoking and you're not a smoker. Even affecting the prenatal aspect, the fetus, the infant, growing children, when they're exposed to this secondhand smoke or environmental smoke. Homes and cars, public environments, where most are non-smoking now, thank goodness. We see that non-smoking environment in restaurants and sporting events. Non-smoking mothers who are exposed to this environmental smoke are exposing their unborn child to some of these tobacco parts like the carbon monoxide and the cotinine, which can be addictive. So parental smoking is a strong determinant to smoking uptake in children and adolescents. It really influences them, and they are more likely to become smokers. And again, please think these adverse pregnancy risks with miscarriage, low birth weight, presentaplevia, previa, where the placenta turns, preterm birth delivery, even stillbirth or SIDS. There's evidence and links that show maternal smoking can even cause orophacial problems. And there is a direct causal relationship in maternal smoking and ectopic pregnancy. So there is nothing that environmental smoke hazards can benefit for any young children. It is a detriment. And this exposure to this passive smoke can just cause asthma, increased middle ear infections, and also different types of respiratory illnesses. Want to look for these oral manifestations when we're looking at intraoral, from whether it's at the lips, when we find out, or if we know our patients have smoked and we're questioning them. It can really, that clinical presentation can vary, but we can really see that the tissues really have some destruction in around the lips, on the palate, and we can really discuss and show this to the patient and maybe see if they're interested in any type of tobacco. Directly linked to periodontal disease and periodontal infections. Tobacco use is a major risk factor in the progression of periodontitis, and they're very high risk for developing more severe periodontitis. And then the new links are starting to see correlations with the electronic delivery systems as well. So we'll see gingivitis, inflammatory response to the biofilm due to the chemicals in the nicotine. We'll see increased tooth loss. A lot of times if someone's a heavy smoker, it's associated with alcohol use as well. We see a lowered host immune response. We see where there's immunosuppression, so that helps, that decreases that periodontal disease, and it has a negative effect on bone metabolism as well, and it contributes to osteoporosis in both men and women. The nicotine addiction, we're back to that again. Again, that's what is called a psychoactive agent. It really makes, remember, those endorphins, makes people feel good, and its use has that increased tolerance and dependence on it. When people start it, anyone that has any type of addiction never intends to become addicted. But it happens, and nicotine's one of the biggest addictive agents in our society. People want to smoke more, or they want to chew or dip, especially that use increases because they like that feel good. So they need more over a period of time. So it reinforces with that dopamine, and when people stop, they have those withdrawal symptoms and they have to have it. More on addiction, if you have ever noticed on a cigarette package or any type of nicotine product, it has the FDA under federal law. Tobacco companies have to say that the statements regarding nicotine, it's addictive and may cause birth defects. But nicotine is the leading addictive drug in tobacco. And they intentionally designed this. It's not easy to quit. It changes that brain chemical. So the way it is designed, it becomes a chronic and progressive disease, despite people knowing that it causes harms. So even though they relapse, people still need that support, and especially from us as dental professionals. A lot of times, again, it's associated with family, peer influences. Sometimes it's associated with existing psychiatric disorders, influences with advertising as well, especially with some of the the vapes nowadays with all the different flavors and cotton candy and bubble gum. Within 24 hours, when people stop, they can experience some physical and psychological withdrawals. The psychologic, behavioral, sensory, and social cultural aspects applied to it, sometimes there's cues or triggers that gives that response that they have to have a cigarette. So that's a lot of times they have to change their habits or who they're around because something triggers that. On average, because nicotine and smoking is an appetite suppressant, people who quit smoking, they don't like it because they're going to gain weight. So even when we're counseling them, we have to help them find ways maybe that they can reduce their food intake or something that that trigger that maybe they can do something different or take a walk or do something, call a friend, anything that we can do to kind of, help with those sensory aspects of the addiction. Going into our counseling, again, we got to think always of our patient-centered communication. We're not trying to persuade the person, but we do want to elicit. Remember our motivational interviewing. And probably the biggest thing, if we do find out, we're always going to ask that in our medical history. That is, are they even interested in stopping smoking or using nicotine? Your text gives about 2/3 of people that have some type of nicotine or tobacco use. They really want to quit, and they have different reasons, but they really have to have that self-efficacy that they want to do it. Either it's their general health, they need a specific health problem, they're coughing, their yellow stained teeth, it's affecting their family, that they want to be a role model, or if they're smoking and they're pregnant. So nowadays, there's a lot of social pressure and restrictions in smoking. And then also they finally will recognize those dangers and want that control in their life. Sometimes young adults, they've seen parents and they don't want to become sick, or they've seen grandparents that have COPD or emphysema, how they suffer. 1/3 of smokers, they really have a difficult time. And then even they need that evidence-based cessation treatment. Sometimes cold turkey is hard to do it, but that's where our support comes in, and we can give them some guides. They can reduce. Some of the guides we can do is give some ideas to reduce daily exposures. Some people thinking that vaping is going to do better than the cigarette smoking, which is not true. We know that. They might look at some over-the-counter nicotine replacements. They might smoke a light version, but there are a lot of different supports to help someone decline or quit using nicotine or tobacco products. There's a lot of what we call pharmacotherapies. Zyban is one big one. That is a prescription. It will help people by counteracting and kind of reducing that nicotine action where it is on the receptor, and it also helps reduce their cravings. They can't use these nicotine use and also keep on using nicotine. There are some over-the-counter ones like the Nicorette gum or the nicotine patches, and then we come into the prescription type of ones like Zyban that they can either talk to their physician about, or if they're interested, the dentist can also prescribe those as well. Aspects of the nicotine replacement therapy, we mentioned the gum, the patch. There's also a nicotine inhaler. You don't see those quite as often, which is kind of related to the nasal spray and also the nicotine lozenges. Pretty much most of these are over the counter. That really does help them, especially when they have a difficult time with that. They can have a 24-hour patch or use a 16-hour patch that really helps to keep that, as we looked in that earlier graph, keeps that nicotine level at easier level where they don't have those peaks and valleys like they do with regular smoking. So usually the lozenge, they can just suck on it because that needs to dissolve. We don't want them biting and chewing it up like a candy. Some of these do have side effects, like a little bit of a stomach upset, and that's something that maybe the patient will have to try different ones that might work best for them. We have some that are actually nicotine-free therapies. The first non-nicotine medication is bupropion, and that is bupropion SR. It is actually prescription strength, and it blocks those receptors. And it is FDA approved for smoking cessation. There are some other non-nicotine as well, but sometimes people will get a little bit of nausea. It's not, you have to be very careful if they're using these non-nicotine and then they're supplementing it with nicotine. And then there's also some of the alternative medications that might not be actually prescribed for nicotine, but they can be a prescription strength. That they haven't really been FDA approved, like clonidine is for muscular tremors, and sometimes that helps with smoking cessation as well. And then some people really seem to have success with acupuncture or hypnosis. Whether those are totally successful, it might work for someone, and they're also using another alternative smoking cessation aid as well. So as far as dental hygiene care for our patient, really when we talk with them, the majority of smokers say they'd like to quit, they may not be ready, or they've said they've tried to quit in the past 12 months. So it's very difficult for this patient, but that is also part of our care plan as well, and how we can refer them to different items that might help in their cessation journey. This is some of the oral effects that we look on tobacco use. We want to look, there's a couple other ones, but this one is called nicotine stomatitis. And this one's pretty severe. In this image, you can kind of see how it looks and presents in the oral cavity. This person's probably a little bit heavier smoker. A lot of times these areas like this are not ulcerated, but most often what you'll see, if you look with my pointer, they're a little bit smaller. You might see some of this redness and a little bit smaller patches. You usually don't see them, these very large patches like you do in this image. And then helping our patients once they're maybe ready to do it, talk to them about that. There is one that's supported by the American Dental Hygiene Association, and it's called the 5 A's approach. And it's also developed by this has been developed by the National Cancer Institute. And we advise, assess their readiness, we assist them, and help arrange ways that they can achieve their smoking cessation and be successful. Here's like a little flow chart. I'm not going to really go into it. It talks about the ask, advise, assess, assist, arrange, and if the patient's ready. And if they are ready, how we can find ways to assist. Can we help them set a set date? A lot of times what's something very successful even in discussing with our patients is right after they've had their teeth cleaned. They're always, yes, I'm motivated right now. And I've seen people do that, maybe have their teeth cleaned in December, and that's a New Year's resolution, and they're successful at that smoking cessation. As we are always talking about our assessment, our patient history, we will ask every single patient, do they use tobacco? Hopefully they're going to tell us no. We'll do our extraoral exam. We do our intraoral exam. We look around, looking at their medical history, if there's any signs of maybe alcohol abuse or other substances that can alter behavior, or tension or stress medications. Looking what their vital signs are. Do they have high blood pressure? See if their extraoral examination, do you notice that they have a smoky odor around them? Because that clings to their hair, their clothes, sometimes noticing their fingers. Sometimes smokers have kind of a yellowish stain on their fingers. And And then a lot of times around the lips, they premature lip wrinkling. We're always maybe even looking that there might even be some precancerous cancerous lesion around the lips. And again, looking at our intraoral to see if there's any visions of nicotine stomatitis or any lesions that we might look at, leukoplakia or erythroplakia, one of those red-white lesions that you'll be talking about in pathology. Looking at our patients, looking at their biofilm control. Do they have a lot of stain? Calculus, is stain and calculus get embedded with that nicotine stain? Have they had, if they're going to be a non-surgical periodontal therapy patient that has some scaling root plating, they're going to have some healing issues. What other instructions do we need to talk with our patient with their diet, nutrition, even exercise, that if they're trying to work with that smoking cessation? Program isn't easy, and it may take multiple interventions or multiple attempts for a patient, but we have excellent opportunity to bring this up and assist our patients and direct them to areas or medications that they might could use to help them. These interventions outcomes depend a lot of times on the motivation of the patient, the experience of the clinician, but sometimes even a minimal intervention by the clinician might help that patient. You never know where you're going to reach that patient. My puppy dog is saying hello. Motivational interviewing, or MI, even just a brief use of your motivational interviews, it can be effective. Just even finding out if the patient is at that point that they're ready to quit or that they might be interested in quitting. You can make a note of that in your documentation. And that way you become more self-confident, maybe with the patient response. If they're not ready, that's okay. Just say, if you are ever ready, just let me know. I can, make some recommendations for you when you're interested. And we're going to ask it. This starts our 5A's again. We're going to ask, looking at all of that in our health history, reviewing with the patients, be empathetic with them. If there's a child or adolescent, or especially adolescents, that's, a lot of times in the United States, adolescents reported smoking cigarettes before 13 years old, and that's probably one of the biggest addictive problems, and especially if they have parents or some type of parental nicotine dependence, they see that it's fine, and they a lot of times will start as well. So look at the patient's history, look at their age. A lot of times the data that's out there, 11 to 13 years old is when a patient is beginning. And now that we're seeing some of these electronic delivery systems, that we're seeing that 11 to 13 is becoming more common. Even though they're not smoking cigarettes, we're seeing maybe that electronic delivery increase. Look, what kind of tobacco fit person? Have they never been a user? Are they a former user? If they're a former user, congratulate them by all means. I will always do that. Current users, just listen, stop. Let them know it's important. Most of the people do. Just look in their mouth if you see any clinical effects. A lot of patients are not going to be impressed about their future health problems, and that's, at least we've mentioned it. A lot of times they know if there's some existing oral conditions, that maybe is a strong motivator. So listen to them, find out why they want to quit. Even asking the patient, are you ready? And that way, if you can, then we're just going to look. If they're not ready, that's their importance. They know the risks. Patients, identify their benefits of quitting. We can always say that. And then sometimes patients might even identify some of their barriers, and we can help them. And just reinforce this motivational message at every appointment with your patient. You never know, again, when that you might make that influence. And next, we're going to assist them. We'll help them establish a quit plan. We might have some practical counseling for them, have the patient tell their family, friends that they're going to quit. They can have a set date, make recommendations for some pharmacotherapies they can look into, and also provide them some educational information and links. And we'll talk about that here. It's associated with our assignment. So that is very beneficial for the patients that you can give them. You can, if they've tried to quit before, they probably know some of the symptoms that they might have with nicotine withdrawal, keep the tobacco out, even, total abstinence is essential. It's hard to just cut down, but that's what some people do, and that's what works for them. Maybe avoiding areas that they, because a lot of times trigger is alcohol. Someone's going to have a drink and they want to smoke a cigarette. Maybe changing, their habits and where they're doing, or if they're with another smoker in the house. Varenicline can also help in relapse prevention. That one's not prescribed as commonly, but it is a pharmacotherapy. And then just actually counseling and talking with the patient and looking at some of the motivational some of the motivational articles that are out there for patients. And, follow up with that patient. That's really helpful for success. Have written documentation. If they had their quit date, talk to them about that. Put their quit date in the area that they're going to see it. Contact the patient. If you know this is something, or if it's someone you know and a regular patient, and they were really interested, call them, send them an email or a text. How's it going? Then if it's, maybe within that first week, if they're having some problems that initial tobacco cessation, sometimes just contact them a few times to let them know you're interested, and in their smoking cessation really makes a big difference. And if they've quit, fine, praise them on their success. If they've relapsed, that's okay. They can, set another quit date and try again. Sometimes it takes up to 10, 15, 30 different times for a patient to quit smoking and be successful at their tobacco cessation. And if the oral health team is all developed in this in a program in your office, it is a very successful. A lot of times the hygienist can be the coordinator, identify tobacco use of the patient. If the patient's going to follow up, or if they want you to follow up, you can kind of act like their coach. Keep a supply of literature for your patients, or know websites that you can go to and print out for them. Of course, your offices are going to be tobacco-free environments. Keep that posted. Have a tobacco use assessment form. And I'm going to show you some literature from Stanford University. And then to put their tobacco status in your records. And just the quick last little A is advocacy. As dental hygienists, we can support community oral health educational programs for tobacco cessation. It can be something that you can look at as a project. Healthcare providers really can help tobacco users quit, or expectant mothers. The CDC has a lot of wonderful information, and there are state-based tobaccos, even in Tennessee, tobacco coalitions in all 50 states. So community oral health education programs, and a lot of excellent materials are available from some of these nonprofit and professional, that you can just print these out for your patient. And as I said, we always document. Put it in our history, what kind of current use, the type of tobacco, what's their age, periodontal health, is their interest and confidence, their motivation and readiness to quit. Have they quit before, and what worked for them, what didn't? Do they smoke? Did they change to another type of tobacco use? All of those are things to document, and we can just express our interest to our patient once again. some of our factors even with our patients. Hopefully they've never started. They're a non-user. Congratulate them. If they're a quitter, if they have quit, great. If they're a smoker, even showing them what we do when they're looking around their mouth. If they have an area of concern, let them see. If there's a pregnant woman who uses some type of tobacco or nicotine product, let them know. Give them some information that it can harm a developing fetus or newborn infant. I have seen expectant mothers have reported to me about vaping or they're trying to quit smoking. And again, if there's any concerns, if any youngsters, young children, 11 to 12, we want to inform them of the hazards of that. And just as a quick story, I had a patient that I kept asking him every time, "You interested in smoking?" He never wanted to. I must have asked him like 50 times. Finally, one day, he came in and he actually told me he was so proud of himself that he had quit smoking. Not sure if he ever relapsed, but while I was still at the practice, he never did again. So they can be successful, even if we express that interest in that patient. And this right here, this assignment link, and I will post it on Blackboard. This is through Stanford University. It has a great tobacco prevention toolkit. It has videos. It focuses on all ages. If this is something that you're ever interested in doing a cessation program, it tells about vaping. It has a lot of activities. And this is something I want you to look at and kind of develop, or even think of someone in your family that might have an issue, or if someone started vaping, or a loved one, or even looking at if you have a patient. What is something, we're going to have a short assignment of something that you can do to help make a plan for this patient to quit and how you would address it.